All right. Hello, everybody. Welcome to our Hypopara Conference 2021. Woo! Yay. So I am here. I'm Patty Keating. I am here with Michelle Reyes, who has been the mastermind behind getting all this together for you. And of course, we have Deb here. And we have Bob as well. And not being able to join us today from the board are Loretta. We miss you, Loretta, and we miss you, Barry. We wish you were here with us. So we're really excited to get started today. And as promised, Michelle's going to do a little tutorial so that you guys know how to navigate the site and you feel really comfortable. And then we will get started with our speakers. So sit back, relax, have a great time with us, and I'll turn it over to Michelle.
Okay. Hello, everybody. So I'm going to share my screen real quick. And this is what you should have seen when you logged in today. Let me hide that. Once you see this and you're on the home screen, hopefully you figured out that you can just click join live stream to join the current session that is active. There is multiple ways to join sessions, especially if you're not planning on sitting in on every session. If you're looking for a particular doctor and you want to make sure you catch that doctor's session, you can click on their picture and it will tell you at what time they are speaking. And if you click on that, it will take you to their session if their session is live. If you click on it and their session is not live, it will tell you that this meeting begins at whatever time it begins at. You can also go over to the agenda on the left-hand side, and it will show you by day. See, the different days are listed at the top, and it will show you what sessions are on that day. So like if I wanted to see what's up tomorrow, and it will tell you based on what time zone you're in, what time the meetings start, and you can just click on the meeting from there. Now, one of the tricks is you will have to, for each session, either go back and click the live stream or click from the agenda on each session individually. It will not automatically flow from one session to the other. Unfortunately, that is the limit of Zoom links. The Zoom links for webinars will not let you automatically go from one session to the other. So hopefully you can all figure out, and we've allowed a little time in the schedule for you to have time to click between sessions. So don't worry about missing any content. There is a help feature under event information, so you can go there. If we need to reach you for announcements, like if we have technical difficulties or anything, I will click an announcement and it will just automatically pop up on your screen, and you can go back to the announcements and review them at a later time. Don't forget to also visit the virtual booths. You can do so by either going to the homepage and scrolling down to the virtual booth and then choosing which one you want to go to. These are for our different pharma companies that are going to be speaking today. And also they have some documents and stuff you can look at in their booths. If you click on sponsors, you can also get back to that same page. If you have questions after each session, you are able to ask questions via the chat function during the session. We will wait and answer those questions. The doctors will answer them at the end of the session. If we don't get to your question, we will try to get them answered and get you the answers posted to our website at a later date and time. There are limited breaks in the agenda. If you've seen, there's limited time between each doctor's and speaker, so please plan accordingly, but also remember that you are not on voice or video. We can't hear or see you. So if you need to get up and go to the bathroom or eat while you're watching the sessions, you're able to do that, and we can't hear any of that. If you want to see any of the bios for any of our speakers, like Dr. Khan, if you click on her name under speakers, her bio comes up, and it will also tell you what sessions she's speaking at. So please use that function. Each session has its own unique link, remember, so please remember to go back and click on it after this session is over. And with that being said, I'm going to stop sharing. Oops. That I apologize. Did it? Oh, stop share. Okay. I would like to now introduce to you Dr. Aliyah Khan. She's from McMaster University in Oakville, Ontario. And she's here today to talk about new guidelines of hypoparathyroidism. Dr. Khan.
Thank you.
Thank you so much. It really is my pleasure to speak to everybody today. And I will be presenting the new guidelines on hypoparathyroidism. So if you can see my slides and you can hear me, we will begin. And here we go. These are my disclosures. So I have received research funding from a number of the industry partners for the development of molecules for treating hypoparathyroidism, as well as osteoporosis. And the disclosures are listed here. So this is the new summary statement for hypoparathyroidism, and we have been working on developing these recommendations over the past 2 years, and this was a major international effort. And this is the team that was involved in developing these hypoparathyroidism guidelines. And so there were 4 teams, actually. We had the epidemiology and financial burden of hypoparathyroidism. And this was led by Bart Clark and Neil Gittos, and it includes international experts from around the globe. And then team 2 was led by Dolores Schobach and Janice Pasica, again, international representation of leaders around the world, looking at how does hypoparathyroidism develop. And then we had team 3, which was led by Michael Manstad and Maria Luisa Brandy, and again, international experts from around the world. And team 4 was how do we evaluate and manage hypoparathyroidism? And this was led by Lars from Denmark and myself from Canada. And again, we have international experts from around the world. So we had approximately 50 individuals working on our hypoparathyroidism task force. And these were the teams. And we have developed 2 types of recommendations. So in science, what we do now is we follow evidence-based medicine. That means that if we make a recommendation, we have to say why we're making that recommendation and what is the evidence to support that recommendation. Is it strong evidence or is it weak evidence? So a strong evidence means that we looked at what are the beneficial effects of therapy and we looked at the harmful effects of therapy. And if the beneficial effects were much, much greater than the harmful effects, then we said, this is a strong recommendation, and we say we recommend this. Or if the harmful effects are far greater than the beneficial effects, we're going to say, this is a strong recommendation. Don't take this stuff. It's bad for you. So we would say the word recommend, that you avoid this stuff or you take this stuff. If the evidence is not that strong, then we will make a weak recommendation. That means there's low certainty of evidence, or we're not really sure if it's going to benefit you or it's not going to benefit you, or there's a close balance between the harm and the benefit. So we'll say, well, you know, you may or may not do that well on it, but we don't really have enough research to make a strong recommendation. And then we'll say, we suggest. And if we don't really have the detailed systematic review that requires framing the questions in a certain manner and doing a systematic evidence search and looking at all of the evidence available, then we can say, well, you know, we don't really have as much research as we would like, but all of us, all 50 experts here, feel that, you know, this is wise based on our experience, based on our knowledge, and based on what we've seen with patient care. But when it's that type of evidence, we say that we propose that this is what happened. So those are the types of recommendations. The hypoparathyroidism task forces have been working on this over the past 2 years, and we have completed, they are in total with the hypoparathyroidism task force and the primary hyperparathyroidism task force, a total of 17 papers that we will be submitting to the Journal of Bone and Mineral Research for publication. And the summary statement, which summarizes the key points from the hypoparathyroidism papers, are going to be presented to you today. So I want to begin by reminding everybody that calcium is sensed by the calcium sensing receptor, which sits on the surface of the chief cells in the parathyroid glands. And when calcium levels are low, it's sensed by the receptor, and the receptor increases the formation and the secretion of parathyroid hormone from the parathyroid glands. And this receptor is a calciostat, and it works like a thermostat. So when the temperature in our house is low, it's sensed by the thermostat, and it tells the furnace it's cold, start working and start producing heat. And so in the same way, the calciostat says, hey, the blood calcium is low. This is dangerous. If your blood calcium is low, your brain needs calcium. You could have a seizure. Your heart needs calcium. You could have what we call an arrhythmia or an electrical irregularity in the heart that could kill you. Your muscles need calcium, so you can get cramping, and the nerves need calcium. You get numbness and tingling, and then go into carpopedal spasm. And so we sense that there's a problem. The receptor senses, hey, calcium is too low. This is not good. And it tells the chief cells, start to produce and secrete more parathyroid hormone. And parathyroid hormone is the main regulator of calcium. Just like the furnace is the regulator of the temperature. Yes, you can open up the windows and get the fans going, but the furnace is what's going to really determine what the temperature is in your house. And so when the calcium is low, parathyroid hormone is increased, and parathyroid hormone's job is to bring that calcium back up. And how does it do that? Well, every day we filter 10 grams of calcium through our kidneys. So 10 grams goes out through the kidneys, and we bring back 9.8 grams. That's a lot of calcium. 10 grams are going out and then being reabsorbed through the kidney. Reabsorbed, actually, this is a typo here. And parathyroid hormone makes sure that happens, and it will enhance that reabsorption through the kidney. So it prevents excess loss through the kidney. So if we don't have parathyroid hormone, calcium levels are low, the chief cells aren't working, or maybe they aren't any there because they've all been removed from surgery, or they're not working because they're damaged, or they've been infiltrated, they've been radiated, or there's cancer or granulomas or iron. For whatever reason, the parathyroid hormone is not there adequately to bring this calcium back through the kidney. So we have what we call a big leak of calcium through the kidney. And all this calcium, if it's not being brought back, it's harmful to the kidney. It causes kidney stones. It causes calcification of the entire renal parenchyma. That means the tissue of the kidney is going to calcify. And it will damage the kidney function. And people with hypoparathyroidism get kidney stones, they get calcification of the kidneys, and the kidney function goes down. And that's bad because we need our kidneys to survive. That's one problem with not having PTH. Not only is the calcium low, so that prevents us from thinking clearly, and it can affect our ability to breathe properly. It can affect our ability of the heart to pump blood effectively. It can affect our muscles from working properly, and it can affect the nervous system. And because we don't have PTH, all this calcium is being lost through the kidney, and that's going to cause kidney stones and damage our kidneys. The next thing that PTH does is it causes bone resorption. So it gets the calcium out of our skeleton. So our skeleton is where we store calcium. It's like the bank for calcium. And when PTH levels are high, we just get the calcium from our bones. And it will activate the osteoclasts, the high PTH, and the osteoclasts attach to the surface of the bone. They release acid and enzymes, and they dig holes in the bone. And they get the calcium and the phosphate out of the bone, and it enters our bloodstream. And so it helps to bring that calcium back, because remember, I said the job of PTH is to bring that calcium back up into the normal range. And it does that by enhancing calcium reabsorption through the kidney and getting the calcium out of our bones. And it also, when it enhances the calcium reabsorption through the kidney, it gets rid of phosphate. So it eliminates phosphate, and it should get rid of phosphate, because when it gets the calcium out of the bones, there's calcium and phosphate entering the bloodstream. So by getting rid of phosphate with the kidney, it helps to maintain that calcium and phosphate in the normal balance. But if we don't have PTH, calcium will be low because we're peeing it out through the kidneys, plus we can't get it out of our bones, and phosphate is high, because PTH is not able to get rid of phosphate because there is no PTH, or there's a resistance to PTH, or it's not able to work properly. And so calcium is low in people who have hypoparathyroidism with all those concerns, and phosphate is high. And having a high phosphate is a problem because it binds with calcium in our brain, and it causes calcium deposits in the brain, basal ganglia calcification. And it can deposit in the eyes and cause cataracts. And we've talked about calcium deposits in the kidneys. So it can deposit in other tissues where we're not supposed to have phosphate binding with calcium and calcifying our other tissues. But that's one of the side effects, or one of the adverse, one of the complications of hypoparathyroidism is having a high phosphate, which is associated with what we call ectopic calcification, because calcium and phosphate is supposed to be deposited in our bones, not in other tissues. Now, if the hypocalcemia persists, the other effect of PTH is to take the 25-hydroxyvitamin D and activate it to become 1,25-dihydroxyvitamin D, or calcitriol, or we call it active vitamin D. So if we activate the vitamin D, then activated vitamin D can help us to absorb calcium and phosphate from the bowel. And that helps us to become more efficient in absorbing the calcium from our bowel. Plus, that 125D is also going to have an effect on getting the calcium out of our bones. So 125D will help PTH to get the calcium out of the skeleton. And so when we don't have PTH, we also don't have 125D, because PTH helps to form 125D. So how do we treat people who have hypoparathyroidism? Well, their calcium is low, so we better give them calcium. Otherwise, they can have a seizure, or go into congestive heart failure, or bronchospasm, get brain fog. And we have to give them calcium, so we can, if they're not too bad, we can give them pills. If they're in an emergency situation, we give it IV. We start a calcium infusion and we start giving IV calcium. And if they don't have PTH, well, they also don't have the active 125D. And so we have to start giving them active vitamin D. And active vitamin D can be given in two forms. We can give calcitriol or alpha calcidol. And alpha calcidol is not as powerful as calcitriol. So I like to use calcitriol. It's twice as powerful as alpha calcidol. And we give calcium and we give rocaltrol or alpha calcidol. So we're giving back the calcium, which isn't there, and we're giving the active form of vitamin D. But ideally, now when we do that, that's good. We're able to correct the calcium. But when we give active vitamin D, what active vitamin D does is it increases calcium and phosphate absorption from the bowel. And we said the phosphate was already high. Well, guess what? It's going to make it even higher. So that's a problem, because yes, we're going to be able to correct the immediate problems, but if we don't correct the phosphate and we make it even worse, then maybe we're helping our patient for today, but we're causing more problems down the road. And that's a concern. We obviously don't want to increase the risk of having chronic kidney disease down the road. We want to improve their symptoms today, but we also want to prevent long-term complications by just giving calcium and active vitamin D. So we have to watch for that. But when we give calcium with food, it can bind to the phosphate in the food and it can help to lower the phosphate. And when we give Rocaltrol, it will help to absorb calcium and phosphate from the bowel. It also causes bone resorption. It can help to improve bone remodeling because it also releases a signaling protein called rank ligand. And so then calcium and phosphate will be released from the skeleton. But ideally, we should give back the missing hormone. We should give back PTH because PTH will correct everything. It will correct the calcium, the low calcium. It will correct the high phosphate because it will eliminate it through the kidney. It will cause the formation of 125D, our own natural 125D. It will increase bone remodeling and repair and allow us to be able to access the calcium from the skeleton. Plus, PTH binds to PTH receptors in the brain, and it can help with brain fog. It can improve our well-being. It can improve our mood. It can reduce anxiety and depression. And it can do all those other things that the missing hormone, was doing, but it's no longer there, or it was never there for people who have had this from birth. So that in a nutshell explains to us what PTH does and what happens when we don't have PTH. So how do we diagnose hypoparathyroidism? We have to have a low calcium and a low PTH or an inappropriately normal PTH, because when the calcium is low, PTH should be high. But if it's not high, that means there's a problem with the parathyroid glands. And we have to check the blood work twice. So do it once and check it again on a second occasion, at least 2 weeks apart. And if we find that our calcium is low and the PTH is not high, which is what it should be doing, if our calcium is low, PTH should be high, trying to get that calcium out of our bones and making sure that we're reabsorbing calcium from the kidneys. So if it's not doing that, then it looks like our parathyroid glands aren't working. And because they're not working, phosphate is going up, and phosphate is bad. It's bad for our vasculature. It causes these long-term complications. And we believe that high phosphate is probably what is causing calcium deposits in the brain and in the kidney. And we have low 125D. And we're losing calcium through the kidney because PTH cannot reabsorb the calcium. So that's how we diagnose hypoparathyroidism. And if someone had surgery, we say that if they have a low calcium and a low PTH or inappropriately normal PTH 12 months after neck surgery, then that's a permanent problem. Because when the surgeon goes in and takes out the abnormal thyroid or parathyroid, they may damage the normal parathyroid tissue. Or sometimes it just becomes stunned and it will recover by itself. And usually if it's going to recover, it'll recover by 12 months. But if it still hasn't recovered by 12 months, then it looks like it's permanent. And when someone has hypoparathyroidism, it's important for us to find out why they have hypoparathyroidism. So we need to find out, is it because of surgery? Is it because of antibodies? Is it because of genetic abnormalities resulting in abnormal parathyroid function, formation and function of the parathyroid glands, or destruction of the parathyroid glands? Is it because we have granulomas in the parathyroid glands, or too much copper or iron that is depositing into the parathyroid glands, or cancer cells are involving the parathyroid glands, or did they get radiated? Or is the magnesium too low or too high? Because magnesium, when it's too low, it causes a resistance to the effects of PTH. Sometimes when people are very sick in the ICU, or if they've had severe burns, then their parathyroid function can also be suppressed. And if a pregnant woman has an overactive parathyroid gland, then the baby's parathyroid glands may not develop. And we have had many pregnant women who have had an overactive parathyroid gland, and we watch them closely. And if they have significantly high calcium during pregnancy, we will do their surgery in the second trimester. And if we don't find out why they have hypoparathyroidism, then we say, well, you have what is called idiopathic. That means we don't know why you have an underactive parathyroid gland. So can we tell who's likely to develop permanent hypoparathyroidism after thyroidectomy? And what we did was we looked at all of the research that has been done. This was done by Michael Manstead and Maria Luisa Brandi's team. And what they found was that if the PTH levels are less than 10 picograms per mil, or 1.05 picomoles per liter for all the Canadians here, then that means that there's a higher risk of having permanent hypoparathyroidism. And this blood test should be done 12 to 24 hours after surgery. And so that's what one of the recommendations that we made. And we said that this was a strong recommendation because there's good evidence that we should be checking PTH 12 to 24 hours after surgery. And if it's lower than this number, then these people need to be followed very closely. They may still recover. The risk of them developing long-term permanent hypoparathyroidism is still less than 50. So there's a 50-50 chance that they may or may not be like that for the rest of their life. 50-50 chance, but they need to be followed. And we also developed an approach to investigating hypoparathyroidism. And we said that if your blood levels are not normal for calcium and PTH, then we have to check magnesium, make sure it's not post-surgical, make sure none of those reversible factors are present. And then we look at our patient and see if they have other features of a syndrome that could cause hypoparathyroidism. And if it is a syndrome, then we recommend that all these genes be evaluated and we do DNA testing. And if they don't have these features of a syndrome, then it's probably what we call isolated hypoparathyroidism, and it can be because of these genetic abnormalities, or we're looking at autosomal dominant hypoparathyroidism, where autosomal dominant hypocalcemia, where we have a mutation in the calcium sensing receptor, and the receptor is super sensitive. And the calcium isn't even that high, but the receptor senses it and turns off PTH. And we would do these DNA testing. So everybody at our center has DNA assessments done, so we know why they have hypoparathyroidism. And we made a recommendation. It was an ungraded recommendation. And we said that we need to know why people have hypoparathyroidism, because it's important for us to know, because it affects our treatment choices. We also look to see what are the complications that occur in people who have hypoparathyroidism. How should we monitor people with hypoparathyroidism? And we also looked at which treatments are best for people with hypoparathyroidism. What is the research showing us in terms of PTH versus no PTH, or conventional therapy, which is calcium and active vitamin D that we talked about? And so we started off looking at like 7,000 records, and we did a big literature search. 7,000 papers were identified. Then we, drill down these and look to see which ones are the most valuable papers. And then we found 81 papers that we looked at. And we said that a complication of hypoparathyroidism was confirmed as a complication if it was reported by at least 3 of those papers, 3 studies. And it had to be much higher in prevalence than people who have normal parathyroid function. And so we then looked at all of these studies, and these are the complications of hypoparathyroidism using the graded approach and using evidence-based medicine. So with the highest level of research that we have available today, we applied it to hypoparathyroidism. And Professor Gordon Guyette, who is the scientist who developed evidence-based medicine, was working with us with his PhD students in ensuring that we were applying the science appropriately to the literature reviews. And we confirmed that cataracts are more commonly seen in people who have hypoparathyroidism. Infections are more commonly seen in people who have hypoparathyroidism. The immune cells need calcium to work. People who have hypoparathyroidism are more likely to get kidney stones and kidney failure. They're more likely to have seizures, depression, ischemic heart disease, and irregularities in their heart rhythm. And then we said, well, what is the best way that we can follow people with hypoparathyroidism? How often should we be testing them? What should we be testing? So we started off and looked at all the literature, and we didn't really find good research to support us making recommendations. So we said, okay, well, we've got 50 people, looking at the hypoparathyroidism recommendations, and 50 people were looking at the hyperparathyroidism recommendations. So overall, we had like 100 people from the international community on our task forces. We said, why don't we ask them what they do based on their experience? What do you do for your people who have hypoparathyroidism? And we said that we will follow this as our recommendation. And so if those individuals, all those international experts, if 70% of them said, yeah, I do this, at least 70% of the time we said, you know what, guys, for all the doctors in the world, you guys should follow this, because this is what the international experts are doing. And the international experts are checking kidney function. Makes sense. Kidney function gets damaged if you have hypoparathyroidism. They're checking calcium. They're checking magnesium. They're checking phosphate, and they're checking vitamin D. It's important to remember that calcium binds to protein. Half of the calcium is bound to proteins. So when we check calcium, we can't just do a simple calcium check. We also have to check albumin and correct the measured calcium for the albumin. And if we don't do that, we get a falsely high or a falsely low calcium. So we have to do albumin corrected. And the international experts are checking urine, creatinine, and calcium. Makes sense. We want to know how much calcium is being lost through the kidney. So we should be checking it. And then they follow these people. They don't just check it once and say goodbye. They'll continue to follow people. And how often do they follow them? Well, it could range from every 3 months to every 12 months. And they check vitamin D again every 6 to 12 months. And when they do follow them every 3 to 12 months, they check their calcium, their kidney function, their phosphorus, and magnesium. So people in the world, doctors, you guys need to do this. You should follow people with hypoparathyroidism. Don't just forget about them. Follow them. Make sure they're doing okay. And follow the urine calcium every 6 months to 2 years. And if your patient is not stable, then follow them more closely. Maybe you have to check it every day. When my patients aren't doing well, I make changes, and then I'll see them in 2 or 3 days. And I want to make sure that that calcium has normalized. And I want to make sure I didn't overshoot or undershoot. So I'm following them very, very closely. And that's what we recommend. And these recommendations, this practice survey was done by Stan Van Oom and Mohammed Shrayef, and they're from Western University and University of Toronto. And this is the conventional therapy. And the conventional therapy involves calcium carbonate or calcium citrate. And you're going to have a lecture on conventional therapy, so I won't belabor the point, but to summarize that, this is what conventional therapy is: taking calcium carbonate or citrate, taking vitamin D, and active vitamin D, which has been hydroxylated. And you could take 0.25 once a day to 3 micrograms total dose, or sometimes even higher. And we can also give hydrochlorothiazide, because this brings back that calcium through the kidney if our patient isn't on PTH. And we know that steady state means that the level in the blood for these molecules has stabilized. And if our patient takes these drugs then we measure half-lives. How long does it take for that drug level to stabilize in the blood? Well, it takes about 5 to 6 half-lives. So with alpha calcidol, in 36 hours, your level has stabilized. In 48 hours with calcitriol, your level has stabilized. So you don't need to check your blood work 6 months down the road after making a change in your medications. You should check it soon. Check it in a week, definitely within a week. And if the patient is not doing well, I check the blood work every day. So then we did a big meta-analysis. We looked at all the literature, the global literature, and we said, now we're going to evaluate all the publications in the world and look to see which is the best option to give to our patients based on the research that we have today. Should we give them PTH therapy, or shall we give them standard of care, which is calcium and active vitamin D? And what are the desirable and the undesirable consequences? And so we said, okay, when we're going to look at these studies, we want to make sure that the studies compared the patient to conventional therapy. So if in a study they only gave PTH and there wasn't a group that was being followed with conventional therapy with active vitamin D, we said, no, that study is not a good study. It may have had a really great result. PTH was fantastic, but the design of the study wasn't good. So we looked at the design of the study. It had to balance, compare PTH to conventional therapy. And so we want to compare, not just PTH alone by itself. We had to do the comparison. We only looked at English language studies. We had to have the comparison over 4 weeks. And we wanted to look at the important patient outcomes, those complications that I mentioned. And we wanted to know, would it have an impact on quality of life? And so when we looked at all of the world literature, there were only 6 studies that met the criteria to be really, really good quality studies. So a drug might be very good, like penicillin. Yeah, it's a really great drug if you have a bug that needs to be killed off with penicillin. But if you don't do the proper study, you haven't proven that penicillin helped your patient. You could say, I'm really feeling wonderful after I took this medicine. But if the research design wasn't perfectly what we want it to be to prove beyond a shadow of a doubt that penicillin killed that bug, then it's not adequate proof. Maybe you got better because you were going to get better anyway. And maybe penicillin didn't really make a difference. Maybe you were going to get better the next day. So if we did a proper study where we gave half the people the drug and half the people not the drug, and we proved beyond a shadow of a doubt that yes, the drug made a difference, then we can say, you know what, this really works. So if the study design isn't perfect, we might not be able to prove that the penicillin killed the bug. So that's why it's important for you to understand this information about study design, because when I'm going to present the results of our meta-analysis, it is going to be interpreted based on the understanding of what we were looking for and what the limitations of our analysis were. And the limitations were that the studies had very few patients. They were small studies and they were not long enough. So if you want to know, does PTH prevent kidney stones from happening? And does PTH prevent chronic kidney disease from developing? Well, we really should have a large patient population and follow these people for 5 to 10 years. If our study is in a small group of people, only for like 4 weeks or a year, it's not going to tell us anything because there aren't enough kidney stones during that time to have an impact. And then we'll say, oh, gee, the drug didn't do anything. It's no good. Well, that isn't the right conclusion. The conclusion is that our research wasn't designed to answer the question. So we recognize the limitations of our research. The studies, they're small, they're not long enough, and they didn't really look at all of those important outcomes that we discussed. But these are the 6 studies that have been done that met the criteria that we were looking at. But look, they're not huge studies. The REPLACE study was 7 months. Tanya Sikjer and colleagues, 6-month trial. And they just have like a couple of 100 people or not even 200 people, small studies. There's small numbers of patients in these studies. So if you look at the Karen Weiner studies, we're looking like maybe less than 100 people. And, this one is for 3 years. This was 2.5 months. This was for 3 years. And then we did a study looking at TransCon PTH. And, we had 44 patients in one arm and 15 in another arm. So 59 patients. And it was a 1-month study where we were comparing active therapy with conventional therapy. So these are small studies, so our evidence isn't very good. But what did we find? We found that, hey, we were able to keep calcium in the normal range. We were able to lower phosphate, which is really great because we want to lower phosphate. And we want to lower urine calcium, but we didn't see that in all of the studies. And part of the problem was the study design. This study, for example, started recombinant human PTH 1 to 84, 100 micrograms a day right away on top of the Rocaltrol or the alpha calcidol. That's a pretty big dose. And so some of those patients became hypercalcemic. Their blood calcium went up. And that could be why there was no reduction in the urine calcium, because the serum calcium was high, so the urine calcium is going to be affected by that. In the REPLACE study, patients were started at 50 and they were gradually increased. But in this study, they were started, boom, 100. And in this study, this was looking at PTH 1 to 34, teriparatide. These two, this one is NatPar, this is NatPar, this is teriparatide. And teriparatide, Karen Weiner did a number of studies with teriparatide. Well, it's actually not teriparatide, it's a molecule that looks like teriparatide. It's synthetic PTH 1 to 34, and she was able to normalize calcium, and she found that urine calcium was possible to reduce. And when she gave it as an infusion, she found that there were even greater impacts on lowering urine calcium and on lowering phosphate, and using very small doses of PTH. And in our study that we did with TransCon PTH, we showed that we were able to normalize calcium, and we were able to reduce the urine calcium that was being eliminated through the kidney. So these results are good, but as you can see, some of the study design was not ideal, and there were small studies and there were short studies. So when we put everything into a pot and we said, okay, what is the bottom line? Look at all of these results together. We found that parathyroid hormone reduces phosphate, which is a very, very good thing. But unfortunately, we found more episodes of hypercalcemia. And part of that was because some of the studies where patients were started on the recombinant human PTH 1 to 84, 100, that's a pretty big dose. Some people just need 25 micrograms of, the 1 to 84 PTH. And that is all they need. Some people need 25, some people need 50, some people need 75, some people need 100, but starting 100 right away, that affected the results of our meta-analysis. So, the bottom line was, when we put all those studies into a pot and looked at them together, we saw hypercalcemia. That's not a good thing, because if you have high blood calcium, it's not good for your kidneys. So when we looked at everything, does PTH improve your quality of life? Well, the SF36 is a scale that helps us to measure how people are doing with PTH. And we found that, yes, there was some improvement. But again, remember, these are relatively small studies, and they were not very long. With people in the conventional therapy, there was no improvement in their quality of life. And when we looked at mental health, they actually got worse in the conventional therapy. But with PTH, there was a little bit of an improvement. What about depression? There was no difference between the two. What about being able to stop your tons and tons of calcium and active vitamin D, which is hard to take, causes stomach upset, and it's difficult to keep on top of it? Well, yes, if you go on PTH, you have a very good chance of being able to reduce the amount of calcium and vitamin D that you're taking. And that's a good thing, because active vitamin D increases phosphate, and we don't want the phosphate to be high. What about side effects? Well, some of the patients, as I mentioned, because the dose of the PTH that was used was 100, boom, right on top of the conventional therapy, did have high calcium. They had some side effects. And so, there were some increases in the side effects, but the quality of the evidence was low. And what about stopping drug therapy? Well, it seemed that slightly you're more likely to stop therapy. But again, the quality of the evidence wasn't that good. So to summarize, PTH decreased phosphate, it decreased the doses of calcium and active vitamin D, but with the small studies that we've done, we didn't really see a big impact on health-related quality of life. And we did see this high risk of high calcium, but that is understandable because of the study design. So with the evidence that we had today, what can we say? What do we recommend? So we had to say, based on the low quality evidence that we have, that, if you have hypoparathyroidism, you can start with calcium and active vitamin D. And if you're not doing well, then go to PTH. But to prove it beyond a shadow of a doubt that PTH is far better and will prevent all those complications, basal ganglia calcification, cataracts, kidney stones, kidney function decline. We need longer studies, obviously. We can't just be walking around with a 7-month trial. We need longer trials. We need years. We need 5 years, long-term studies. And we need bigger studies. We need to have a larger number of patients involved in these trials. And so our ungraded recommendations were that we would recommend patients start with calcium and active vitamin D, and the goal has to be raise the calcium into the lower half of the normal reference range. It's not a good idea to aim for a super duper calcium, because if you need very high doses of Rocaltrol to get your super duper calcium, you're hurting your future. Because the higher your calcium, the higher your urine calcium will be. And if you need a lot of active vitamin D, that means your phosphate is higher as well. And that could cause kidney damage. We don't want you to have hypocalcemia. That's not good, obviously. But we also don't want you to have a high blood calcium. And we want to normalize that urine calcium. Because if you have a high urine calcium, that probably is associated with an increased risk of kidney stones. And kidney stones are bad. And we want to bring that phosphate down. And one of the ways that we can do that is by asking patients to take calcium with their food. So it's not a good idea to take all your calcium as one big lump in the morning. You should spread it out and take it every time you eat. So take calcium with breakfast, lunch, and dinner. So it will bind the phosphate in the food and get rid of it in the stool. And use active vitamin D carefully. Don't take tons and tons of it, even though you might feel really great when your calcium is super normal. We don't want it to be high, obviously, otherwise it'll cause dehydration and cause other complications. We do want it to be normal, but it doesn't have to be in the upper normal range. Just get into the normal range or just below the normal range to make sure that we don't cause long-term complications. We also need to normalize magnesium, because magnesium can act on the calcium sensing receptor and turn off PTH. And magnesium is also important for the effects of PTH to happen. So if you have inadequate PTH, then you have, inadequate magnesium, then you have a resistance to PTH. So we have to normalize magnesium, and we need to normalize vitamin D as well. And we need to correct that urine calcium. You might need hydrochlorothiazide to bring that calcium back in. And it's a good idea to take a low salt diet, because salt causes us to lose calcium through the kidney. And think about PTH if you're not doing well. If you're on the calcium roller coaster, you're high, and then your calcium is high, you end up in hospital, all your supplements are cut back, Rocaltrol is cut back, you go out and nobody's following you closely, you drop. then you become hypo. Then they put up your doses, you go up again. This is the roller coaster. When you're exercising, your calcium requirements are increased. If you don't have adequate control, then you're going to drop your calcium. So we need to get you off the calcium roller coaster. We want your calcium levels to be stable. What about pregnancy? Well, there are a few things that happen during pregnancy. And during pregnancy, the breasts produce a hormone called PTHRP, which acts like PTH. And the placenta produces PTHRP as well. And these levels start to rise in the 3rd week of pregnancy. And they start to rise and they act like PTH. So pregnant women may not require as much calcium and rocaltrol during pregnancy. But we need to monitor them very closely because PTHRP can form the active 125D that people with hypoparathyroidism don't have. And that increases the absorption of calcium and phosphate in the bowel. And so it's important for us during pregnancy, especially to follow patients closely. And if we follow patients closely, then we're able to improve the mother's outcome, because if you have a low serum calcium, it can cause the mother to go into labor. And if we're following patients carefully and keeping that calcium in the normal range, we will ensure that the baby's parathyroid gland develops properly as well. And my patients who are pregnant with hypoparathyroidism, I'm monitoring them very, very closely. But sometimes they don't come back for follow-up. And sometimes they don't take their pills. And that's really sad because they're not only hurting themselves, they're hurting their unborn baby. So during pregnancy, it's absolutely critical that we monitor very closely and keep that calcium in the normal reference range. And that's what we say, that in pregnancy, monitor every 3 to 4 weeks. And during the month prior and after, monitor even more closely. And the endocrinologist has to work with the obstetrician and the pediatrician. And the drugs that are safe during pregnancy are calcium and active vitamin D. We're not recommending that PTH be used during pregnancy, and thiazide diuretics should not be used in pregnancy. And there's a lot of new research happening, and the treatment strategies for hypoparathyroidism are going to expand dramatically, because we have very, very valuable molecules that are being investigated right now and that will become available very soon for general use. And one of those molecules is a long-acting PTH analog, which is a molecule that consists of PTH and PTHRP. And this binds to the signaling to the PTH receptor, and it has a very short half-life, but it continues to act on the receptor. So it allows the effects of this molecule to persist for a long time period, and it can help to eliminate those elevations and reductions in calcium. And there was another molecule, this was a pill that was being developed but had to be stopped because patients developed liver toxicity. And then there are molecules that are antagonists of the calcium sensing receptor. So they block the calcium sensing receptor and they allow a natural rise in PTH, and they allow the kidneys to reabsorb calcium. And those are being evaluated. And then we have TransCon PTH. And I showed some of this data to you.
I'm going to put my hand up in there.
Very valuable data showing us that this is a prodrug, and this can actually last in the circulation for 60 hours. It has been shown to normalize calcium, and it can reduce phosphate levels and significantly improve quality of life, and it can reduce urine calcium. So this is very exciting molecule, and it's actually in phase 3 trials right now. So it's the closest to becoming available for general use. So with that, I would like to thank you all for your attention, and I would be happy to answer any questions.
Okay, just a reminder to the attendees, we are probably not going to get to all these wonderful questions you've submitted because there is a lot of them, Dr. Khan, but I'm going to start out with some. From Melanie, we have the question, what is the best way to lower your phosphate?
That's a really great question, Melanie. And I recommend that you go on a low phosphate diet. And phosphate is present in dairy products. Dairy products are rich in phosphate. But if you take products like almond milk has calcium, but it doesn't have phosphate. And you can take your calcium with your meals because that'll bind the phosphate that's present there. But avoid boxed foods, canned foods, and meats. If you have a very high meat intake, that has phosphate, and high dairy products and colas, these foods are rich in phosphate. So go on a low phosphate diet and ensure that you're not taking your calcium without your food, because if you take your calcium with your food, then it will bind the phosphate in the food and get rid of it. And then try and use as little of the active vitamin D as possible. And, take more calcium, less active vitamin D and C if you can normalize the phosphate. And if it's not possible, then consider PTH therapy, because PTH will get rid of that phosphate through the kidney. But it is important to normalize phosphate.
Thank you. We now have a question from Kimberly. Is there any research or info on how low PTH or calcium affects your breathing? She says she has low lung capacity since becoming hypopara, and she wonders if it's related.
Yes, absolutely. We know that one of the complications of hypoparathyroidism is bronchospasm. And I had one patient who had asthma, and when she became hypocalcemic, she actually went into stridor. She had laryngospasm, and she couldn't breathe. And her mom actually called 911. And that's how her hypocalcemia presented. So you can get laryngospasm, you can get bronchospasm, and, check your calcium levels. If you're having more difficulty with breathing, try and get that calcium in the low normal reference range, and make sure that your calcium is checked with albumin, and check the ionized calcium. You want to have fewer fluctuations in serum calcium, because it can affect the breathing. It can affect the ability of the heart to pump blood. So it can cause congestive heart failure. One patient presented with congestive heart failure, and he was severely hypocalcemic in Northern Ontario. And, so these are important complications. Respiratory and cardiac complications are potentially lethal complications of hypoparathyroidism.
Okay, our next question comes from Alex, and he wants to know, would alpha calcidiol be worth exploring for a patient that has detectable PTH, and when they take calcitriol, it causes a calcium spike midday?
Well, what I would do, that's a really great question. So calcitriol is more potent than alpha calcidol, but I would give a lower dose of the calcitriol. And maybe you don't need calcitriol if you're getting hypercalcemic. So the lowest dose that you can do is 0.25 micrograms a day, or you can start taking it less frequently. You don't have to take it every day. You could take it maybe 3 times a week, or maybe just twice a week. So I would go down to I actually don't like to use alpha calcidol. It's not as potent. It has a longer half-life. It takes a longer time to wash out. If you become hypercalcemic, it takes a longer time to wash out. So I don't like alpha calcidol. I like calcitriol, but you don't have to take it every day. If 0.25 micrograms once a day is too much, that's a good thing. That means that you have some parathyroid activity. And you just need a bit of an augmentation, and you could take it maybe 3 times a week, or twice a week, or maybe just once a week. And you could take some more calcium supplements.
Okay, our next question is from Caddy, and, from Kim. And Kim wants to know, since cataracts are a complication, how often should we be getting eye exams, and starting at what time frame from the onset of their hypoparathyroidism?
Yeah, that's a really good question. And unfortunately, I don't have good evidence to answer your question because we haven't done the proper research studies. But what I recommend is that if you're having visual impairment, then obviously you should be seeing an ophthalmologist. If you're having any symptoms at all, you can have an eye examination. But you'll notice that we didn't say do an eye examination for everybody. But if you have non-surgical hypoparathyroidism, that means you have hypoparathyroidism and you haven't had a surgery and it's one of the genetic forms of hypoparathyroidism, then having an eye examination, a baseline eye examination is a good idea, but you don't have to keep having it repeated. So we don't have clear-cut recommendations on how often you should have those eye examinations, but doing it at baseline is a good idea. But I don't have evidence to say, hey, you need to be doing an eye examination, a slit lamp examination every year or every 5 years. We don't have that evidence to make a recommendation.
Okay, Dr. Khan, thank you so much for all your presentation today and for answering those questions. Unfortunately, we're going to have to cut questions off right now, guys. And we are going to get those answers to you and try to get them posted to our website. We are going to be starting the next session with Ascendus in about 4 minutes. So we will need you guys to log into that live stream. You'll have to click off this one and log into that live stream. Thank you again, Dr. Khan.
Thanks so much. Bye. Thank you.
So I'm going to end this one, leave webinar, and then we go to Ascendus and start that one.